Why don't we get started, everyone? Good morning. Nice to see everybody on this cold day. I wanted to remind you also that, remember, we have the new system for getting your CME credit, which is Francine put into the chat about texting the number, which is the same number every week to that telephone number once you link it to your CME account. So if you have any issues with that, please reach out to Francine. And with that, I will get ready to turn over to Dr. Levin to introduce our speaker. Emily, you're up.
Thanks, Dr. Thomas. Good morning, everyone. Welcome to Grand Rounds. Today, we're joined by Dr. Peter Goulden, who is the Division Chief of the Division of Endocrinology, Diabetes, and Metabolism at Mount Sinai Morningside in West, and Associate Professor at Icahn School of Medicine at Mount Sinai. He trained in the UK at the University of Edinburgh and completed his fellowship in London. Before taking on his current leadership role at Mount Sinai, he served as the director of the diabetes program at the University of Arkansas from 2012 to 2019, where he led the statewide annual diabetes update with the Arkansas Department of Health. And prior to this, he wrote a regional multidisciplinary diabetes strategy while in the UK and was given 4 clinical excellence awards in recognition of his work in diabetes. As an NHS consultant, he served as the Regional Diabetes Network Chair for West Kent for 5 years, creating a regional plan for diabetes care. And he is a fellow of the Royal College of Physicians of London. He serves on the International Advisor Board of the Royal College and on the editorial board of the Journal of Obesity and Chronic Diseases. A very warm welcome to Dr. Goulden.
Thank you very much, Emily, for that kind introduction. I'm going to start my slide share. Great. Okay. So no disclosures, first of all, and really just in today's presentation, what I hope to do, is talk very much about some key themes in type 2 diabetes management. And what I really hope to do is talk about some of the key care standards that we apply in our patients, in whichever branch of medicine we cover. Each of us comes into contact with patients with type 2 diabetes on a daily basis. And what I also hope to do this morning is, describe, glycemic goal setting for our patients as well and how we can optimize that with a particular focus on hypoglycemia as well, which can be a real challenge. So I'm really just going to start with some just general background and really, what we've been seeing, in recent history and perhaps some topical issues as well in type 2 diabetes. And I think, first of all, many people will have seen these CDC maps of diabetes and obesity over the last decade or two. And these maps now actually show prevalence of diabetes and obesity. And what we can see, as we move through most of the last 2 decades is, this map gradually turning darker shades of green. And that's reflecting higher prevalence of both obesity and type 2 diabetes. So we can see that link is extremely strong. And that's a concern in terms of, service planning for the future. Really one of the key things that came out towards the end of the last year in relation to this topic is the impact of COVID on this as well. And, in terms of the COVID pandemic, we've talked about the obesity pandemic, the diabetes pandemic, and there really is an overlap. And when we look at what happened between 2018 and 2020, the number of states with high obesity rates actually doubled just over a 2-year period. And there's a real concern as to, what may be impacting this. If we look at the impact of that on healthcare, the cost is of the order of nearly $150 billion. We know that with our COVID patients with diabetes, we've all come into contact with these patients in hospital, and we're seeing increased risk of hospitalization and death. In terms of the impacts of COVID on obesity and diabetes, they've really started to look at this, and we know that the impact is multifactorial. One of the common things we're seeing, particularly in endocrinology clinic, is patients complaining of 20 pounds of weight gain, not uncommon during the pandemic, and the impact of that on diabetes prevalence moving forward is going to be concerning. So what about COVID and diabetes in our inpatients and what's happened there? So this was a whole population study from England, 60 million whole population study looking at risks of in-hospital death between March and May. And what we found was that the odds ratio for in-hospital death for patients with type 2 diabetes was twice that, much higher for patients with type 1 diabetes. And what's interesting is that even when this was adjusted for previous history of coronary artery disease, cerebrovascular disease, and heart failure, even with that, we still saw almost 1.8 times risk of death in patients with diabetes. And we know that this effect of hypoglycemia on the immune system and immune health is likely one of the underlying reasons for this. So thinking about type 2 diabetes and what is the natural history, in terms of how these patients present and how they progress from pre-diabetes, which affects nearly 40% of the population, through to diabetes. And it's often, we start by seeing this rise in post-meal glucose and a steady trend upwards in fasting glucose. And it has been argued that by the time of diagnosis and the onset of diabetes, patients may have lost as much as half of their beta cell function. And that's where we then see this term that's been applied, the Starling curve of the pancreas, where this increasing insulin resistance that's occurring, the pancreas is trying to respond by making additional insulin, and then it reaches a point where there's a decompensation, and we see this presentation of patients with type 2 diabetes. I think it's good to go back to, for these patients, thinking about what can we do, what can we achieve, in terms of A1C lowering, and what does that 1% reduction in A1C mean for that individual? And this is, of course, an old study now, the UK PDS study going back to 2000. But there are some key messages that came out of that. And I think often it's trying to get that message across in the clinic that just a 1% reduction in A1C can have nearly a 40% reduction on the impact of microvascular complications, but also cardiovascular disease, death from diabetes, and amputation as well. So that 1% actually, it's such a small number, but a huge impact. So in terms of how we're doing with diabetes care, and this was a report from the CDC on goals achieved. It was the National Diabetes Statistics Report, and it was US adults over the age of 18 between 2013 and 2016. And the first question they asked was, do you have one provider who's providing your diabetes care? And about nearly 80% said they did have one healthcare professional managing their diabetes. When it came to physical activity, the story was not as good. Only 24% were meeting this recommended goal of 150 minutes, which I think, that is a key concern. And we know during the pandemic, this has also been an issue. Weight management, interestingly, a number of people quite a significant number had talked about managing or losing weight to reduce their risk. And then finally, statin therapy. So for patients over the age of 40 with type 2 diabetes, about 58% were on statin therapy. We've got to remember that one of the ADA recommendations is that everybody over the age of 40 with diabetes should be offered statin therapy. So that's another concerning number. So if we look at the same report and setting goals for our patients, such as A1C, blood pressure, lipid lowering, and also smoking cessation, and we can take more stringent goals than A1C of less than 7 or less stringent. And for all of those goals, what they found was that it was only about 20% of patients were reaching all 4 goals, which again is a concern. And also with an A1C of less than 8%, about 36%. So that was a bit of background, in terms of where we are with type 2 diabetes right now. What I'm going to do in the next section is really get into the optimizing care, talking first of all about screening and goal setting. And what I really want to focus on is some of the key areas around hypoglycemia today as well, and what we're hoping to achieve for our patients in preventing hypoglycemia, individualizing care. And then finally, in the last part, I'll talk about some examples of education approaches that we've used in a number of settings. So first of all, screening. What is the official line on screening? So for patients with a BMI of greater than or equal to 25 or greater than or equal to 23 in Asian Americans and at least one risk factor, such as hypertension, then it's recommended screening at least at 3-year intervals, and often we'll want to screen more frequently than that. In individuals without risk factors, the American Diabetes Association recommends testing begin at age 45. So really from age 45 onwards, this is part of the process we should be following. So what are the risk factors we're thinking about for patients who are overweight or falling into this category of BMI of greater than 25 or 23? So the first thing is one of these risk factors, only one of these needs to apply. So it could include a first degree relative with diabetes, being in a higher risk ethnicity group, history of cardiovascular disease, hypertension, dyslipidemia, history of PCOS. And I think this one, number 7, is an interesting one, physical inactivity. So you can remember from that earlier slide, this applies to a large proportion of individuals. So immediately, a lot of people are in that category where they're going to be eligible for the screening. And then also the conditions associated with insulin resistance that we may see. And in terms of patients who are asymptomatic, who've been diagnosed with pre-diabetes, then yearly would be the goal. And where there is more of a concern, we may test more frequently than that if we're more concerned about rapid progression. For patients who have a history of gestational diabetes, lifelong testing is recommended. And as I say, 45 is really the cutoff to start testing, with ongoing follow-up after that. And I think it's good just to remind of these cutoffs for these tests that we do. So whether it be the fasting glucose or the A1C, and both of these are used in screening in the clinic setting. I mean, the A1C has the advantage. It can be done when the patient's coming into clinic in the afternoon, they're non-fasted. But there have been some schools of thought and some evidence to say that the A1C may miss a proportion of cases, and in terms of its sensitivity. And there are other factors which can impact A1C as well, of course. So it's not a perfect tool. And I think often this needs to be interpreted in light of the clinical picture, the overall clinical picture with that patient. So that was about screening. And I think what I hope to do now is get into the key part of this, which is really goal setting, glycemic targets, and hypoglycemia avoidance for our patients as well. And really the key here, and I think I would say this for any patient we see with type 2 diabetes, comes back to these 4 cornerstones of diabetes care: nutrition, physical activity, glucose monitoring, and medication adherence. And if those 4 cornerstones are in place, we're likely to get a good outcome for our patients. In terms of those measures and taking lifestyle measures, this is a slide from the American Association of Clinical Endocrinologists. And I think if we apply nutrition, physical activity, and apply these rules such as the 150 minutes a week of exercise, which goes back to the DPP study, that is a key. Focusing on weight management, managing BMI. Things which often may not get covered, though, include sleep. So thinking about, is the patient getting 7 hours of sleep per night? There is some evidence out there that actually poor sleep quality can impact glycemic management. And also, of course, we know that as for a number of our patients with obesity, they will have symptoms of signs of obstructive sleep apnea. And I think really screening those patients and reflecting on that is important. And then behavioral support is also a key area. For patients with type 2 diabetes, it's been shown that the risk of depression can be up to 3 times that of the general population. And that can have a huge impact in how someone manages their diabetes. And so screening for this and managing this effectively can really have an impact. So as I said earlier, in terms of A1C and when we're screening for these patients, the evidence is there in terms of the benefits that we can achieve with A1C lowering, whether it be retinopathy, nephropathy, and neuropathy, and macrovascular disease. And the key, I think, really with any patient that we see is really looking at how we can achieve these outcomes. What about cardiovascular disease and patients with type 2 diabetes? What is the impact of glycemic control on long-term cardiovascular risk? And this is a slide which was a follow-on from the DCCT study, an older study now in type 1 diabetes. And the EDIC study looked at the impact of that intensive control further down the line in terms of non-fatal MI, stroke, and cardiovascular death. And really what you can see from this is that intensive control, it takes some time to see that manifestation of better outcomes for the patient. We're talking about over a decade. And what that means is that, where appropriate, getting good glycemic control, excellent glycemic control early on can have an impact further down the line. And in terms of American Diabetes Association goals and for most patients in general, these are the goals that we're aiming for. So a pre-meal glucose of 80 to 130 and a post-meal glucose of less than 180. And I think if we can achieve that, then we can get better outcomes. That doesn't apply to everybody, though. And in particularly more elderly populations, we're thinking about, can there be a need to really individualize those goals for that patient? And this slide here really is reflecting on patients over the age of 65 with diabetes. And for a younger patient who's healthy with very few coexisting illnesses, tighter glycemic targets are going to be more appropriate versus a patient who's got multiple comorbidities, is at risk of hypoglycemia, which I'll be talking more about in a moment. We want to set perhaps more sensible goals, more pragmatic goals, which minimize the risk to that patient. And this actually was a slide. It was a joint position statement from the American Diabetes Association and American Geriatric Society some years ago about looking at individualizing targets for these patients. What about hospitalized patients that we see with diabetes? I think it's important to cover that as well. And so, as we know, for a majority of patients who are hospitalized with diabetes, a target glucose range of 140 to 180 is going to be recommended for the majority of patients in hospital. And the reason for that being is we're not really aiming for overly tight control, which may increase the risk of hypoglycemia, particularly when patients may not be eating or fasted. There may be some cases where maybe we may look at targets were a little tighter than that, but never at the expense of hypoglycemia. And really involving the specialized diabetes or glucose management team, which is present at each site in the Mount Sinai system, can really help. And I think for anyone who's been admitted, for one reason or another, I think often the diabetes is a co-diagnosis, but I think it's good to ask a couple of key questions early on to say, is there something different this patient is going to learn? I was speaking to one of our educators the other day, and she highlighted a good point. Just learning to inject insulin involves many steps. And when people are admitted, there are many things which can impact their education. I think getting a consult for patients who may need support early on from the endocrinology team or diabetes education team can also have an impact as well. And I think insulin education itself actually does take time. There's first of all the impact of patients learning about their diagnosis of diabetes, which itself can produce anxiety. Teaching can be interrupted when patients are in hospital, so we have to often work around that, and it can need to occur over a few days. And sometimes just when people are getting towards the end of their stay, that reception to more detailed or complicated teaching can be a challenge. So again, what I would say with this is early referral is key. Over at Morningside and West, we have two nurse practitioners who provide the majority of our inpatient diabetes care. Ella here is focused very much on our surgery, vascular surgery, cardiothoracic surgery. And Francisco has more of an interest in elderly diabetes as well. So with our team, each individual member has their own focus in terms of diabetes care. And what I would say is involving the endocrinology team early on, where there's felt to be a need for in more intensive diabetes management. And we know that the evidence supports this, the literature supports this, that if that referral is made early in the stay, it will shorten the length of stay. If it's made right on the day of discharge, not surprisingly, it will lengthen the day of stay, the hospital stay. So moving on from inpatient goal setting and really setting goals, I talked then about really achieving risk factor control for patients with type 2 diabetes. And this is a study that was published in New England Journal just last year, and really looking at outcomes for patients over the last decade. And this is really highlighting trends in diabetes and control, and really want to focus on glycemic control and what's happened over the last couple of decades. And we saw between the year 2000 and 2010, really a steady improvement. The orange line here is the less stringent goal, A1C of less than 8, blue line, A1C of less than 7. And things tend to stabilize at this point. There was a slight leveling off then. What we see after that period is things really reach more of a plateau. So about 50% of patients leading up to 2018 achieving that more stringent goal and 75% less than 8. And again, interestingly, I think if we look at blood pressure control, also some plateau, and lipid control as well. And when we look at all risk factors combined, only about 1 in 5 achieving that multiple risk factor control. So I think that's important in terms of cardiovascular risk and a key message. And what they said in terms of the editorials on this was that after a decade of progress, there'd been more of a leveling off in these managements. The reason was not quite clear, but may herald increasing complication rates over the next decade. And again, a really important need to underscore the importance of comprehensive risk factor management for these patients. So that's a little on goal setting and glycemic targets in patients with type 2 diabetes. And what I'm going to do now is move on to really a key area for these patients, which is really hypoglycemia and hypoglycemia avoidance. And I think the first thing I would like to do is really just describe, a real world example. 62-year-old gentleman who came into clinic, the history of type 2 diabetes, and he was on 55 units of basal insulin plus metformin, 1 gram twice a day. And there was a history of multiple low glucose levels, but not getting any symptoms from his hypoglycemia, which was the key. And his A1C was 8.9%. And what we did for him was a CGM, and this was, very telling. You can see that he was going hypoglycemic every night, and that's pretty dramatic. You can see this rapid drop in glucose. And then what was happening was when he was checking his glucose in the morning and bringing his records in, this is what had been seen. But essentially, he was on far too much insulin, and really concerning because he's going hypoglycemic every night, and that's going to have real consequences and risks for him. And we use this term over-basalization. It's been referred to recently in the American Diabetes Association guidelines. What is it? So it really is about excess basal insulin. And there's a real key need to recognize this and reduce the basal dose where this is a problem. And what are the signals that might, highlight that there may be over-basalization? So the first thing is just anyone who's on more than half a unit per kilogram could potentially fall into this group. If there's a significant differential, and by that I mean a drop of over 50 points between the bedtime glucose and the morning glucose, that can also be a signal for potential over-basalization. Hypoglycemia unawareness, where people are getting minimal symptoms, is another concern, but also high variability, where people are getting very erratic blood glucose readings. And, we've heard this term brittle diabetes, but that can sometimes be associated with this. So what about hypoglycemia unawareness? And, what are the issues with this? And we know that there's this reduction in this autonomic sympathetic response. We know that it's associated with duration of diabetes and is commoner in older patients with diabetes as well, but really can have real significant consequences in terms of hypoglycemia, seizure risk, falls, fractures, many of these things. And the management is actually straightforward. It really is about often talking about short-term relaxation of glycemic targets, really scrupulous avoidance of hypoglycemia, and often really cutting right back on the insulin for a number of weeks and allowing the glucose levels to run higher to try and regain that sensitivity to symptoms. And there's some good evidence that this approach can work. When we look at hypoglycemia, and in recent years, there's been moved towards a classification of level 1, level 2, and level 3 hypoglycemia. What is that? So level 1 is very much this biochemical cutoff of 70 milligrams per deciliter, and patients falling below that range. As we see hypoglycemia at lower levels, less than 54, then the risk increases to the individual. That's not to say there's not a risk at level 1, but the risk rises. And this term, clinically significant hypoglycemia, really highlights this lower level that we're seeing and need to avoid that. And finally, level 3 is the older definition of hypoglycemia requiring third-party assistance. So again, these can all be signals that there really is an issue with management. In terms of hypoglycemia and hospitalizations, so this was a study from Diabetes Care looking at hospitalizations from the late 90s up to 2013. And what we saw that there was an increase in hospitalizations over time. But interestingly, if we look at then at the incidence of this, it then tended to reach a plateau later on. But if we look at what happened with this, it was 1 in 9 patients were reporting 1 episode of severe hypoglycemia per year, which is, a real concern. 1 in 100 had an emergency department visit. And again, more common in type 1 than type 2. But the key message that came out of this report was that more severe hypoglycemia were occurring in those with type 2. And the harms that occur with hypoglycemia can be varied, from just reduced quality of life. If you ask someone in clinic, what's their big concern with diabetes management, it really will be, often many will say hypoglycemia. And we know that one severe episode can impact how someone manages their diabetes for up to 12 months or more afterwards. Hypoglycemia and unawareness I've talked about. There's a risk of falls and fractures. We know that hypoglycemia has an effect on the myocardium with prolongation of the QT interval, so a risk of dysrhythmias, and also for more elderly patients, impact on cognitive function, and finally mortality, so a real significant risk for these. Looking what's happening at the level of the nervous system, we know that there's this, essentially, with these patients who are getting multiple hypoglycemic episodes, we see this attenuated sympathetic response to hypoglycemia. So there's a reduced sympathetic response when the blood sugar is dropping. And we know that recurrent hypoglycemia essentially leads to an ongoing blunting to these responses, this fight or flight syndrome. It's very varied from one patient to the next. Some patients may complain of flushing, sweating, palpitations, very varied, but essentially we see a reduction in these. And we know that for patients who do have this impaired response, their risk of severe hypoglycemia from this study was up to 25 times that of other individuals. So it really drives up the risk in terms of severe hypoglycemia. Looking down at the level of the individual and looking at risk factors on the individual level, when we look at this impaired counter-regulation, it really boils down to 2 simple things. It's either going to be too much insulin or too little glucose. And in terms of too much insulin, first of all, the patient may have worsening kidney disease. We often see that with patients who've been on a fixed dose of insulin for some time, develop problems with their kidneys, and their dose really needs cutting back significantly, definitely often by more than 50%. Just having mistimed insulin doses, mistiming of insulin and food, dose too high for that individual, all of those can be drivers, versus just too little glucose. And there are many factors which can affect this beyond the missed meal. We know liver disease, impaired glycogen reserves can be a driver, alcohol, physical activity, gastroparesis, and even food insecurity. So a number of factors which can really drive that. And, looking at risk at the level of the individual and all the factors that drive that, they fall under really 5 broad areas. So first of all, the complexity for that individual, their duration of diabetes, their number of previous hypoglycemic events, their frailty, multiple comorbidities. For those patients, their risk is going much higher. Patients with dementia, pharmacotherapy is another key area. So patients who are on higher risk medications, sulfonylureas can be an issue, and also beta blockers, good to mention those, which can attenuate that sympathetic response. And then finally, other factors which can include the patient context environment, which can be complex, and a number of other areas. So really just important to highlight that. At the level of systems, we talked about goal setting, and making sure that goal setting is tailored to the individual is often the key. When we look at hypoglycemia and through the ages, and it was a BMJ study from Miller et al. In 2010, definitely over time, we find that there is this increased risk of hypoglycemia in this study. And again, that's concerning because for these individuals, the risk is going to be higher. So again, and this was from the Accord study, which targeted an A1C at a lower level for these. And we saw a significant rise as time went on. Looking at hypoglycemia and A1C goal setting, so we set this goal of less than 7% for a majority of patients, and this actually looks at the risk of hypoglycemia versus A1C. And we know that as that A1C heads down below 7, that risk of hypoglycemia and hospitalization, which is being shown on the y-axis here, tends to rise. And, from the Accord study a few years ago, which targeted A1C of less than 6, study that was stopped early as well, what we found was that, there is this potential also a mortality risk associated with this. So again, pragmatic goal setting, 7% is appropriate for many, sometimes maybe highest for others to reduce that risk. In 2014, it was looked at what might be the commonest precipitants for people coming into the ED with hypoglycemia. And interestingly, precipitating factors were only documented about 1 in 5 cases. But, for a majority, it was timing of insulin glucose. And that's not surprising. About 1 in 5, took the wrong insulin product. That's not uncommon, particularly it's often easier done than we might think. Sometimes just confusing the unit dose, accidentally taking an additional dose. All of those can be drivers. And sometimes, it's people feeling, really the patient feeling that they can share that information with their provider where that's happened. I definitely would say with hypoglycemia, individuals may not always volunteer this information in clinic. And, in terms of that, just doing a very basic assessment, even just 1 or 2 questions tagged onto the visit is important. And it has been shown that it isn't always asked in clinic, but definitely when we do, and when we do kind of create a situation where the patient can share that information, we can start to have an impact. And in one study, this was looking at patients who'd had severe hypoglycemia. Only just over half of them actually automatically shared that event with their provider. And of course, this is driven often by fear of sharing that information. So sometimes direct questions in a sensitive way can really help. So what about the impact of education for these patients when we were wanting to prevent hypoglycemia? And there was a study some years ago. It was called the Dose Adjustment for Normal Eating. And this looked at structured education delivered for patients with diabetes, UK-based study. And it was a program that was delivered over 5 days. It was delivered 9 to 5. And essentially, it would be a group education session, usually 8 to 10 patients delivered with a number of diabetes educators, with very much a focus on insulin dose adjustment and really essentially creating an expert patient who's comfortable with adjusting their insulin, for various factors, exercise, sick day management, etc. But also there was an element of peer support in this and sharing within that group setting. And the studies were very clear on this program that actually there was an improvement in A1C, quality of life, but also a reduction in hypoglycemia from taking this structured approach. And when we look at these targets and balancing these risks and hypoglycemia risk reduction, again, it's coming back to setting a target of, more versus less stringent and thinking about the individual. The American Diabetes Association guidelines actually have a good section on, what should be the approach when we're concerned about hypoglycemia risk and, what treatment should we be using. And I think it's looking really particularly at insulin and secretagogues and thinking, is it possible to simplify the insulin regime? Can we substitute something else for a sulfonylurea, which can be a real trigger of hypoglycemia in elderly patients? And really thinking about, options such as the DPPs, GLP-1s or SGLT2s as other options for those individuals. So, that's really been a view of hypoglycemia. And I think, briefly what I hope to do next is to talk about some of the recent developments in technology, in diabetes management. But I think with technology itself, again, it's really good to take things back to the individual patient level. And I have to be honest, this slide here, I think, highlights what can be a real challenge for a lot of people. It's not uncommon that people struggle with glucose meters, and this has been studied, significantly. In one series, about 1 in 4 patients could not interpret what was happening with their glucose meter. 4 out of 10 struggled with calculating their carbohydrates, and nearly 1 in 3 had difficulty dosing insulin correctly. And this was coming back to numeracy, literacy skills in relation to the glucose meter and just the very basic technology that people are using to manage their diabetes. So again, being sensitive to that, I think, is key. We've seen some big advances in diabetes technology, in the last few decades. This shows one of the very first insulin pumps, moving forward now, we now see more and more of patients who are using this technology as well. But the different types that we have, can vary from the disposable patch pump to the more complex technology as well. Various approaches, and this can really help patients who have more complex diabetes needs. What I want to highlight here in relation today is actually, continuous glucose monitoring technology as well, and the fact that more and more patients are using this. We know that, for our patients, this is something that really applies to people who are using 4 doses of insulin per day in terms of this technology, but can really have a significant impact. And for patients who are using that kind of continuous glucose monitor, what we'll see more and more now is this report, what we call the Ambulatory Glucose Profile Report, or AGP report. And the American Diabetes Association, really say that the goal for patients who are wearing one of these devices should be that they be in target range for over 70% of the time for patients that we're aiming for, A1C of less than 7. And that target range is a glucose between 70 to 180. Where I think this is really useful, and I think particularly in the clinic setting, is where we can even do this just now over a 2-week period, or what we can call a professional continuous glucose monitor, a bit like the patient I just showed earlier. And that can highlight where these patients may be getting hypoglycemia and where we may need to target this. So I think, it has a number of useful roles, but more than anything, I think what patients say is that really visualizing what's happening with their blood glucose really can impact how they manage their diabetes. And the time in range that I talked about there is really helpful when it's taken in conjunction with the A1C. So particularly a 70% time in range corresponds to an A1C of around 7%. And a 10% increase or decrease in that can actually add or subtract about a half from the A1C. So again, more information which can really help individuals with managing their diabetes. And where this technology is going is very much down the miniaturization route. So, now really rather than wearing something that's a larger size, this is getting smaller and smaller and really less obtrusive for patients, which is often one of their concerns, and really is going to make it much easier in terms of diabetes management. In terms of type 2 diabetes and things which are on their horizon, I think 2 things I just want to highlight today. First of all, insulin Icahn, which is a once-weekly insulin, which has been going through trials, which may have a potential role for patients where insulin delivery is a real issue. So that's going to be very interesting to see where that will go. And then finally, also the twin cretins. There was a good study on these published in the New England Journal last year. And these is a class of medications which act both on GLP-1 receptors and GIP receptors, which can impact both weight and blood glucose outcomes as well. So really, good developments on the horizon for these patients. So moving on, in terms of the diabetes care standards and what we're aiming for patients, and really starting to put these pieces of the jigsaw together. One of the themes I really hope to cover in today's talk is individualizing care. And we talked about in detail about risks associated with hypoglycemia, but also good to think about disease duration, comorbidities, life expectancy, established vascular complications, but also, a critical one, patient preference, resources. And I think, again, applying these, that can often help us, really guide us in terms of where we should be aiming to individualize that target for that patient. The other thing I would say in terms of individualization, I think what's been exciting, particularly over the last 2 decades now, has been the large number of cardiovascular trials that we've had. And this dates back to just after 2000, when we'd had the issue with the glitazones in patients with diabetes and adverse cardiovascular outcomes. And as a result of that, we saw this real focus on really getting trials set up for patients for newer type 2 diabetes therapies. And that's really given us a wealth of data, which has really impacted how we manage this. And particularly for the SGLT2 inhibitors and GLP-1 agonists, when we look at cardiac risk and both renal risk, we really see significant reductions in endpoints. And particularly, what I've done here is underline the studies and the evidence where we actually have primary endpoint data, but also we have secondary endpoint data, and particularly for the SGLT2s, first of all, seeing this real reduction in heart failure admissions, hard renal endpoints as well. And that really has had a big impact in terms of where we may use these patients. But in GLP-1s, in terms of secondary outcomes, we also see benefits in terms of stroke risk, and definitely an overlap between these two classes of medications. And so I think for a lot of patients now with type 2 diabetes, we're often asking the question, would this patient benefit from a GLP-1 or SGLT2 in terms of their management to reduce their these endpoints for them? And this now has been really hardwired into the American Diabetes Association practice guidelines, looking at, really how we might individualize the treatment for the individual and homing in on patients with cardiovascular risk or heart failure. Really, as I say, an SGLT2 being placed, high up for that population, or potentially a GLP-1 for patients with atherosclerotic cardiovascular disease. For patients with chronic kidney disease, again, considering an SGLT2, or in some cases, a GLP-1 where an SGLT2 may not be tolerated or contraindicated. So really, again, focusing on this individualization of targets for the patient, I think is the key. And, I've covered hypoglycemia in detail, but the other area that covered in these guidelines is the need to minimize weight gain or promote weight loss. And again, GLP-1s really can have a big impact there. We now have once weekly GLP-1s, which also have FDA approval purely for weight loss as well, which is the other advantage. And finally, important always to talk about cost, where cost is an issue, and really being, thinking about, practically for the patient, what's doable, what's not doable, thinking about other treatments which are going to really impact that. Because again, what we don't want to do is have that patient go to the pharmacist and really end up with a treatment that's been prescribed, which just they can't afford. So I think that's important to highlight that, and that's also recommended mentioned in the guidelines as well. So that's important in terms of the guidelines, but in terms of delivering those guidelines, what are the key things to be aware of? So this term clinical inertia has been applied, and so this is the time to treatment escalation in patients with type 2 diabetes. And in this study, they looked at patients on a single agent with an A1C above 7% and looked at the time to actually escalate their treatment. And this was a retrospective cohort study, but what they found was that, if you take patients of over than 8% A1C, that it was up to 1.5 years before that treatment was changed, before additional treatment was added. And hopefully this is improving, but again, it's just food for thought that clinical inertia can be a challenge. Clinical inertia can be driven by many factors. It can be at the physician level, setting goals with the patient, looking at comorbidities such as depression, as I talked about earlier, having adequate time to actually use the clinical encounter to get the right outcomes for the patients. Could be patient-related factors. Denial is a common one, but also low health literacy, just not getting the messages sometimes. And I think cost, as we know, can be a challenge, and having that often open communication to try and get around this can have a big impact. Depression, as I've said earlier, again, common in patients with type 2 diabetes and a real barrier in terms of the impact on the individual. So these are all key areas which can be a challenge. And I think if we can, be mindful of these, I think that can really help us get through this clinical inertia that can be a problem. So in the closing part of the presentation, what I'd like to do is really just talk about, again, putting this together, diabetes education for patients with type 2 diabetes, and really give examples of, 2 real world studies that I myself was involved in, and really how we hope to tailor the diabetes management in these 2 groups that we looked at. And the reason I highlight this is we know that diabetes education in terms of the individual can be just as powerful as medication in many people. And this slide just highlights the impact of medical nutrition therapy on A1C. And this looks at the medical nutrition arm of a number of studies. So we've got the UK PDS study, DCCT study, Daphne study that I'd mentioned earlier. And for all of these examples, one of the focuses was really on optimizing medical nutrition therapy, whether it be at the group level or the individual level. And the theme that came out of all of these trials, that when you look purely at the impact of nutrition therapy, that there was an A1C impact of, over 1% in terms of those individuals. So this just highlights how that straightforward education about lifestyle can really produce better outcomes. And so education really can have that big impact. And the Daphne trial that I'd mentioned earlier just highlighted that in terms of that education delivered over 5 days intensively with a dietitian and a nurse specialist. And what they found in that study was that the A1C at the 6-month period had benefited. Interestingly, by the 12-month period, there was some significant loss of that benefit. And what they found was that that initial program had to be reinforced. And what they did as a result of this data was then introduce refresher programs. So essentially, as well as that initial piece of information delivered in that 5-day course, delivering refreshers to try and really keep that information fresh over time. And I think in terms of education itself and where education may impact A1C, that the key theme in terms of this meta-analysis that was published was that it really boils down to promotion of self-management, really supporting the individual to really be able to self-manage and really achieve those outcomes. And if we can do that, then that will really achieve one of the highest benefits in terms of A1C lowering. In terms of diabetes education, this was a project that I did in Kent some years ago. We looked at the population in the local area, and particularly just a very straightforward thing to see what proportion of our patients had received diabetes structured education. And, it was the numbers at that time were not good. It was less than 10%. And out of that came really a need then to demonstrate, need for running more group classes for our patients with diabetes, running joint group classes between primary and specialist care, and creation of what we called an intermediate care tier in the area as well, and really to try and get a more joined up approach on diabetes education. So just what I'm going to do now is just talk through really that diabetes education as applied to two populations that I dealt with during my time in Arkansas, and really just what came out in terms of learning of that diabetes education as well. And these two areas which I'm going to describe include the Delta region of Arkansas, which is a high diabetes prevalence region, with also higher levels of issues with health literacy and numeracy. But also I'll be talking about population in the Northwest region as well, a population of particularly high prevalence of diabetes, and that's the Marshallese, and what we learned in terms of how there's a real need to, again, individualize and tailor education. So the first project we did, it was 2013, some years ago now, and this was in the early days of telemedicine, before things have advanced quite rapidly in recent years. But we essentially, it was a small project that we did with 20 subjects in the Helena region in Arkansas Delta. And we were very lucky that there was a local RN who had an interest in diabetes management who we worked closely with in terms of these patients. And we delivered just 2 hours of group education, just a small group education session. We kept the group sizes quite small, between 6 and 8 patients. We had 2 diabetes educators working on the project as well. And we've focused very much on basic diabetes medical nutrition therapy. And then over a period of 8 weeks, really followed and reinforced those principles from that initial 2-hour session using individualized telemedicine visits for those patients. And the subjects who were in the study that we did, average age of 54, diabetes duration of nearly 7 years, and A1C about 8.9%, BMI of 33.9 in terms of the group that we looked at. And the kind of setup that we followed was having the local site actually support the check-in process of that patient on a weekly basis, sending the glucose records to the endocrinologists and specialist nurse, and then really putting that data together on a weekly basis, really talking with individuals about what had happened with regards physical activity, nutrition, again, coming back to those cornerstones, in the previous week, and then trying to talk through really how they could use that data positively. And it was very much delivering simple messages despite, using the technology to achieve that. And what we found that over the course of the study, there was a significant reduction in A1C and also, significant outcome for those individuals. And in the last couple of minutes now, before I close, what I'm going to do is describe the other project that we delivered as well, which was in the Marshallese. So the Marshallese are a Pacific Island community in Northwest Arkansas, nearly 10 to 12,000 in numbers. And actually, interestingly, a little known fact that Arkansas has the largest Marshallese population in the continental US. And going back to the 80s, an agreement was made which allowed the Marshallese to live, work, and study in the US without a visa or permanent resident card. And the reasons for that really go back to some of the history of this population as well. And essentially, as a Pacific Island population, up until the 1950s, they had a very low prevalence of diabetes. And unfortunately, due to weapons testing in the 50s, the islands were exposed to significant levels of radiation. There were real major effects on the food chain. And in terms of, what happened with this population was they went very much from a diet which was low in carbohydrate to really, reliance on processed foods, imported foods. And this led to a process of migration over time as well. And essentially what happened was they moved from a very much a healthy life to very much a westernized diet in a very short space of time. And what was found was this population then suffered extremely high rates and prevalence of diabetes. And these are numbers from Arkansas and the Hawaii area as well. And essentially for patients with, uncontrolled diabetes, nearly 1 in 3, but a majority of these patients having abnormal glucose levels. And it was felt this was due to this rapid change in diet and lifestyle, possibly a genetic component, which is less certain, but lack of preventative care, lack of health education. All these were issues because as they moved across to Arkansas, etc., often access to healthcare was an issue, and also because the fact they came in and may not have insurance coverage. So we really looked then at how we could deliver structured education geared to this population. I was lucky to work with a population in Northwest Arkansas who really involved the community in terms of this. And what had been noted was that they'd struggled previously as a population in terms of getting the right outcomes. So we came up with the idea of looking at something called the family model. So many interventions often target the individual, but we don't often think about how does the family impact diabetes. And there is a link, there's some evidence that actually family support can have an impact, and actually having a good family knowledge of diabetes can also impact this. So we did a pilot study initially where we took the education into the home with the family present, and we adapted the curriculum to the culture as well. So Marshallese foods, really trying to understand that. And we actually had impact from the Marshallese, input from the Marshallese in terms of designing that curriculum. And I think the key to success was having a superb team, which were very engaged and worked across the community as well. And what we found was that, there were some challenges. And one of the key messages was that, for most people who were, receiving the education, it was very difficult to eat differently to the rest of the family. That was the key issue, and they struggled with that. So often trying to get the whole family to make a change bore down to the level of individual in terms of achieving the better results. And from that, we then followed on with a larger scale study, a randomized trial, where we went for either a structured education, which was more standardized, American Diabetes Association, versus an individualized model, which actually followed these principles based on the local community. And essentially it was going to be very much, then we looked at the outcomes for those, and we actually had over 300 participants and collected data pre, post, 6 and 12 months as well. And essentially by the end of the study, what we found was that and I'm going to highlight, I'm really, in the interest of time, I'm going to bring things to a close fairly shortly. But what we found was that there was significant reduction in A1C in those individuals who received the family education, some in the standard education, but less so. So really targeting that support of the family really produced better outcomes for those individuals. So, to summarize, I think what I'd like to say is what I've hoped to do today in today's talk is talk really about patients with diabetes, how we really have to think about at the individual level, whether it be goal setting, what's happening in their environment, really focus on hypoglycemia avoidance, really being aware of that and how that can impact that individual. And I think very much, tailoring that treatment to the individual, based on the standards of care and all the evidence that we have. I think technology is providing options, but very much, I think if we get these 4 basics right, in terms of those 4 cornerstones of care, I think we can really achieve those best outcomes for the patient. Thank you very much.
Great. Thank you, Dr. Goulden. That was a very interesting talk. Really appreciate your patient-centered approach. We have time for a couple questions if people want to put them in the chat. There is one there already, Peter, if you can. Dr. Greenberg wrote, since patients may have hypoglycemia in the middle of the night, do you wake them up to check the glucose level?
That's a great question. I think it's a concern. I do ask patients in clinic to check a glucose level in the morning. I have asked them to do that where I'm concerned. I don't do that frequently. I do it where I'm concerned that someone might be at risk of overnight hypoglycemia. I think it can have a role. You don't want to be doing it frequently because it can often be extremely disruptive. But where there is a concern, I've asked people to check, you can ask people to check a 2 to 3 a.m. glucose reading. The other thing where there is a concern can be, besides cutting back on treatment, can be sometimes the use of a bedtime snack as well. But yeah, definitely it can be helpful to ask them to check a glucose, particularly if we don't have access on the continuous glucose monitoring.
Right. There's something else came in. Emily wrote, if people have discordant fasting glucose, postprandial glucose A1C, do you preferentially target one of these measures?
Yeah, it's a nice one. I think when we look at the individual and looking at the fasting glucose versus the prandial glucose and A1C, I think it's best to always look at what the real-time data is showing for that individual, and that is the glucose monitoring. So the A1C is going to give you a snapshot of the last 3 months, but as I said, there are many things which can impact the A1C. So I think looking at the individual in terms of preferentially targeting those, we know that from the NHANES study for patients above target, often ensuring the basal insulin is correct first can be extremely helpful. And again, avoiding this phenomenon of over-basalization. And then once that basal insulin dose is correct, then focusing in on those postprandial values as well.
Oops, Dr. Seward says, is there an A1C above which at onset of drug treatment, sole use of metformin is not advised?
Yeah. So with regards use of metformin, it really is right there at the center of most type 2 diabetes management algorithms. With regards to this, and I think when we're assessing a new patient who's presenting with diabetes, we're often wanting to think, what is the level of beta cell function? Is this patient insulin deficient? I think that's an important question. For patients who are, earlier on in the diagnosis, metformin is still going to give benefit most likely, but it is likely that more than one treatment will be needed to achieve goal. And we know that metformin will lower the A1C up to 2 percentage points. So for example, a patient presenting with an A1C of 10 or 11, you're probably going to get them down to 9 maximum. So it's likely you're going to need 2 agents or more. I think for patients who've had diabetes for a longer period, or, there's maybe a history of rapid weight loss and you're questioning, what's going on, then I think sometimes checking a C-peptide and glucose can be very useful just to assess what's going on at the level of the beta cell, to look for beta cell deficiency. Because, clearly then if they are insulin deficient, then actually we're going to be thinking more about insulin therapy. But for majority of patients, I would say that metformin should be used early on. And, where we think we need an additional agent, really getting the patient back to clinic early to assess then about add-on therapy.
And so there's a lot of people on this call that are primary care providers for people with diabetes as well as specialists. And I wonder, Peter, are there lessons learned from your study that you did around with the families that we could implement here in our care of patients in the city?
I do think so. I think although this was, a very specific population, the fact, I think the broad theme that comes out of that is that, when an individual has to make changes, if the environment around them isn't supporting those changes, and that definitely includes the family, it's going to make it much harder for the individuals. So where possible, I think family members coming to diabetes education visits, nutrition appointments, I think can really help. Number one, because they gain insight, I think, into what's happening with the long-term diabetes management, but why it's important for that individual to make changes so there aren't potential other factors, outside the individual that could sabotage their attempts to improve their lifestyle.
I think Dr. Seward is seeing what I was thinking, and that your work with this population taught us so much. So that's really so thank you very much.
Thank you.
So Peter, Dr. Goulden, thank you very much for your talk today. It was really great to have you come visit us at the Mount Sinai Hospital Grand Round. So have a nice day, everybody. Stay warm out there, and see you all soon. Have a great day. Thanks, Peter, again.
Thank you.